Okay. So I'm Carson and my partners are Lucas and Autumn, and our injury is a shoulder dislocation. So there's three different types of dislocations. In the anterior dislocation, the head of the humerus moves in front of the glenoid socket, and they're the most common type of dislocation, and they usually occur when there's a blow to an abducted, externally rotated, and extended arm. In the posterior dislocation, the head of the humerus goes behind and above the glenoid, and they're not very common, but usually they occur when there's a blow to the anterior shoulder and axial loading of an adducted and internally rotated arm. In the inferior dislocation, the head of the humerus is pushed down out of the glenoid, and they're pretty rare, but they usually occur when there's a hyperabduction or there's axial loading on an abducted arm. And all these dislocations can be complete or a subluxation, and it's also pretty likely that you're going to dislocate your shoulder again after the first dislocation. So some symptoms you'll see with the shoulder dislocation is shoulder deformity, inability to move your shoulder, intense pain and discomfort, swelling and or numbness and weakness. So to diagnose your shoulder dislocation, first, there's going to be a physical examination to test for any kind of injury to the axillary nerve, brachial plexus, and blood vessels. Then after that, they'll do an x-ray so they can see the direction of the dislocation and check to see if there are any fractures or lesions in the area. And also, after you get your shoulder popped back into place, it's possible that you'll need an MRI to check for any tears in the tissue around the shoulder. Okay, so the tissues affected in the anterior dislocation, you're most likely going to see a labrum tear or a fracture of the glenoid fossa, or the humeral head, and possibly even nerve damage. And then in the posterior dislocation, there's a high risk of fracturing the surgical neck, tuberosity, or the head of the humerus. And there's also a chance of injuring the labrum and rotator cuff. And then lastly, in the inferior dislocation, you're more likely to see axillary nerve damage, tears of the internal capsule, and rotator cuff injuries as well.
So I'll be discussing the structure and function of the tissues affected when a shoulder dislocation occurs. First, the glenoid labrum, which is a fibrocartilaginous tissue, hard word, that encircles the glenoid cavity. It provides static stability to the glenohumeral joint and seals both sides of the joint together. Next, we have the glenoid cavity or glenoid fossa, which is a shallow depression on the scapula. It allows the head of the humerus to move freely, enabling the arm to move. We also have the head of the humerus, which is a proximal portion of the humerus and is shaped as a hemisphere. It serves as the ball for the ball and socket joint produced by the glenoid cavity and the head of the humerus. We also have the greater tubercle, which is the bony bump located laterally to the head of the humerus. It acts as the attachment site for two of the muscles that make the rotator cuff, the infraspinatus and the supraspinatus muscles. We also have the axillary nerve, which is a peripheral nerve that is formed within the axillary region or the armpit. The function is that it innervates the deltoid and teres minor muscles. And lastly, we have the rotator cuff, which is composed of four muscles: the supraspinatus, the infraspinatus, the teres minor and subscapularis muscles. And the rotator cuff allows for arm movement and to keep the humerus in the socket.
Okay, once the shoulder has been reduced to its normal position, you can start rehab. Rehab will vary in length depending on the degree of the shoulder instability and laxity of the ligament, if it was an acute versus chronic condition. So like the severity of the dislocation, is surgery needed, are the ligaments torn? The length of the time that your shoulder needs to be immobilized, the strength and range of motion status, and your performance and activity demands. Do you need to use your upper body at work? Are you in a sport? The rehabilitation program will be broken down into 3 phases. First-time dislocators may be immobilized for 2 to 6 weeks before starting physical therapy, and recurrent dislocators, physical therapy can begin immediately. All exercises in phase 1 and 2 Caution must be applied in placing undue stress on the anterior joint capsule as a dynamic joint stability is restored. And phase 3 is focusing on progressive exercises to prepare for the return to prior activity level. So in phase 1, the main goal is to regain passive motion and eliminate pain. Supplementary measures that you can use are pain medications as needed, icing the shoulder for a maximum of 10 to 15 minutes at a time, and wearing a shoulder immobilizer at all times except during the exercises. The goal of these exercises is to reduce stiffness and some pain in the shoulder. So you can do the Codman's pendulum, which is up on the right, and it's just swinging your shoulder back and forth, letting it hang freely. Passive shoulder flexion and abduction, and then elbow, wrist, active range of motion to just get that joint moving. Some precautions, so you want to avoid provocative positions of the shoulder that risk instability. So like the cocking position in a throw, and avoid shoulder extension. In phase 2, the goals are to regain full active range of motion, reestablish your shoulder stability and increase dynamic stability, as well as increase strength and discontinue the use of the sling. You can also continue with ice and pain medications as you would like. So you're going to continue for the exercises with all the phase 1 exercises and then add in active assisted range of motion and progress to active range of motion to gain mobility in the shoulder. And for assistance, you can use a dowel, or right here we have like a pulley system. And then you also have shoulder isometrics, which strengthen the shoulder without actually moving the shoulder. So shoulder flexion, extension, abduction, adduction, external rotation, and internal rotation. And in the final phase, this is the strengthening phase. So you want to maintain full and painless range of motion. Continue to strengthen your rotator cuff, your scapular stabilizers, your deltoid. Increase neuromuscular control and retrain proprioception of your shoulder. That's knowing where a joint is in space. So that way you're able to better stabilize your shoulder. And we want to return you to your activity prior. Your exercises are going to be continued from phase 2 with including isotonic strengthening with TheraBands, starting with low resistance, moving up the resistance, and then finally progressing to free weights, as well as advanced external rotation and internal rotation, as you see in this bottom right. Weight bearing exercises, which can be a push-up progression. So for instance, doing a push-up against the wall, to on the table, to on your knees. And then finally, you can progress to more advanced plyometrics and overhead exercises that are going to be more strengthening. And that is our presentation.